Good afternoon, everyone. Thank you for joining us for our next session, the federal update, will they ever lower the cost of insulin and other drugs? We are very grateful for our two presenters, George Huntley and Jacob Jansen, who are here from DPAC, amongst other names and titles that are associated with them. Just as we begin the session, just a friendly reminder that you have been hearing all day. There will be a very brief Q&A at the end of this session, probably about 5 or 10 minutes worth of questions, most likely 5. But you are, both our presenters will be sticking around afterwards outside to answer questions. We do have a hard stop at 4:30 because we have the banquet tonight and they need to start setting up in here. If you have an elementary or Kiddie Cove or child in Kiddie Cove, just a reminder that you have to pick them up as soon as the session ends. So that way, again, our people can move on to their next step. We're interested in feedback for all of these sessions, so please make sure that you fill out the survey on your table, or you can fill out the information in the app. We would greatly appreciate that. Masks are not required throughout the conference, but if you feel more comfortable wearing one, please feel free to do so. But otherwise, I don't want to take up any more time, so I turn this over to both George and Jacob. Thank you so much for being here.
Oh, this is great. This is our music. All right, thank you. Thanks very much. Much appreciated. So for those of you in the front, if you could move all the way to the back, because the back row is seeming lonely, I think that would make it helpful, don't you think? And those in the back, if you want to go back another step further, that would be better, because man, it's really hard to see people back there. Are you having trouble seeing people?
I see a couple.
You see a couple.
Yeah.
You see a couple. That's great. Well, thank you for spending your day with us. You're an hour, the next hour, and he said it's gonna end with Q&A. It's gonna end with Q. I'm not so sure about the A, but we'll do our best. I am George Huntley. I don't look like that, but I am George Huntley. I am the CEO of the Diabetes Patient Advocacy Coalition, as well as the Diabetes Leadership Council. I'm a green bracelet, living with type 1 diabetes for 39 years. I have a sister, niece, and great nephew, all with type 1. I am also I'm a past national chair of the board of the American Diabetes Association. In my other job, I am the chief financial officer of a professional services firm based out of Indianapolis, Indiana. In that role, I've been the plan administrator of a self-insured health plan for over 25 years. So the health insurance business, which we're going to talk about, is the cost of insulin, cost of drugs. I've lived the employer perspective of that. And I am honored to be with my esteemed colleague, Jacob Jansen. Jacob, why don't you say hi and tell us a little about yourself?
All right. Hi. Good afternoon, everyone. My name is Jacob Jansen. I am the communications and policy lead here at the Diabetes Patient Advocacy Coalition. I joined DPAC straight out of graduate school, where I went to the University of Kentucky to get my master's in public administration, as well as a certificate in nonprofit management. Before that, I spent several sessions in the Kentucky legislature working with a government affairs firm, Babbage co-founder, who I also still currently work with, as well as spending some time at the local level in Ohio politics and abroad in the United Kingdom, working in the House of Parliament. So thank you all for joining us today. And hope we can answer some questions.
We will. And Jacob has got nothing. He denies any culpability in Boris Johnson's departure today.
He was not prime minister when I worked there. So, yeah, exactly.
Okay. So let's talk a little bit about DPAC, the Diabetes Patient Advocacy Coalition. Our mission is to ensure quality of and access to care, medications, and devices for patients living with diabetes, and also, very importantly, to educate, inspire, and empower patient advocates, everybody in this room, especially the ones in the far back, as well as lawmakers, toward meaningful action on diabetes to improve our lives and care. Go back one, just a little segment. So how do we do this? We train people in the diabetes community. That's what this is about. We train, we provide advocate training. And, we understand that government can feel intimidating. It is sometimes, how many in this room have ever talked to somebody in government to lobby and ask them to do something? Okay, several hands up, which is great, and several hands that are not up. So hopefully when we're done today, two things will happen. One is you will be pissed off enough to want to go do it. And second, you'll feel confident in your ability to do it. So can you strike that last? I shouldn't have probably started with that. If it's going to be recorded, I apologize for those listening at home. But that's what we're here to do. We want to empower you to do it. We do the heavy lifting so that you don't have to. DPAC is proudly affiliated with the Diabetes Leadership Council. In full disclosure, I am the CEO of both of these two organizations. We affiliated these organizations during the pandemic. DLC is a policy shop. Everybody on the Diabetes Leadership Council board is a past leader of a national diabetes organization. Many like me were past national chairs of the board of the American Diabetes Association. Jasmine Gonzalez was just in here doing a presentation. If you were listening to her, she's also just joining the DLC board. DPAC is, are you?
Look at that.
I'm not doing that. Did I do that? Hi there. Okay. At no time did my fingers leave my hands. So DPAC turns knowledge into action through advocacy, so we have a grassroots army of champions at DPAC. So thousands of advocates across the country. All 50 states are covered by DPAC advocates, and we are trying to grow that database because the more people we have, the bigger the army, the more we can amplify and get our voices heard. So without further ado, let's start with the drivers of the cost of insulin. I'm wondering if this has got a timer on it.
There shouldn't be, but
Because I swear I didn't touch it. But
I'll take very careful measures.
why don't you talk about the drivers of the cost of insulin? Let's start with that.
So to start, we're all very well aware of the fact that list price for insulin has gone up 141% over the past 10 years. However, if we're looking at it from a full perspective, we also see that net price for insulin, which is the price that insurance plans are paying, is down 53%. So at the end of the day, people with diabetes are being overcharged for the life-saving insulin when they're being exposed to this list price instead of that net or flat net price. And so the question is, why is this happening? And the answer, to a certain extent, there's several factors, but one of the largest answers is rebates. Now, when Medicare was created in 2003 under the MMA, it established the Medicare drug benefit, but what it also did is it created a legal pathway for price negotiations by exempting rebates from the federal anti-kickback statute. So essentially to say that these middlemen called pharmacy benefit managers were able to negotiate with pharmaceutical manufacturers, including insulin manufacturers, to establish formularies and pricing. And during those negotiations, one of the biggest selling points are these rebates. And under Medicare, they're entirely legal, and they're able to extract from the insulin manufacturers very, very high rebates, which in turn starts to get into that distinction between list price and net price.
So as we think about this and the cost of insulin, and these numbers here are from me buying insulin in Indiana. Okay, so the list price was $334 for the vial of Novolog that I was purchasing. My plan, because I'm the plan administrator, we pass rebates through to our participants. So my net cost of a vial of insulin was $85. Now it's still way too high. $85 is unaffordable, but it's a heck of a lot better than $334. And so you look at that difference in price, and that is a massive number. And why are list prices going up, but net prices going down? Well, competition is growing in the insulin market. Insulin is not a monopoly drug, right? There's back in the days where you had the EpiPen and there was only one player in the marketplace. There's many people in the marketplace. There's three main manufacturers now. There's a fourth with Viatris making a biosimilar. We're going to talk about all those folks. There are many players in the insulin market today. Typically in the free market economy, when there are many players in the marketplace, prices are kept down. And that net price that Jacob was showing on that other slide proves that. It's working. The marketplace is working. It's just not working for you. You know, it's working fine for the insurance companies and the PBMs. It's just not working well for us because list prices are going up because the manufacturer is quite happy to provide as much rebate as the PBM wants. They're just going to raise the list price because the manufacturer wants what it wants. And we can, again, talk all day long about is 85 too high or is, you know, yes, it is. But, you know, the 334 is insane. Other comment I want to make is to reference to back to the 2003, that's when the Medicare Part D law went into effect. It actually started, they passed it in 2003. It took them to 2006 to enact it. If you look at that graph that started in 2010 or 11 and you went back to 2006, all right, that's when that whole delta started. That's when that list versus net price gap started occurring. And it was all by, you know, the road to hell's paved with good intentions. That's what happened when they made this law. So let's talk about the money trail. How is this playing? Any questions on this slide? Okay, I usually get that answer. So a consumer, that's us. This isn't going to show up on white. So we're at the top of the chain as we should be, right? We're going to the pharmacy to get our insulin. And this is true of any drug. I'm going to do the scenario based on insulin, but it's true of any drug. So we're going and we're buying insulin and we're paying the pharmacist for that insulin. Now, if it's during our deductible period, we're paying the full freight, right? If we're after our deductible period, we're paying a copay typically, right? Nobody complains typically about the copay. All of the complaints are about I'm in the deductible period and I'm paying $1,000 for my vials of insulin because I'm exposed to list price even though I am fully insured. I've got insurance. I've paid a premium. So the other thing you can see up in that consumer, I'm paying an insurance premium. So I'm sending money to the insurance company or the health plan or the employer because I'm a self-insured employer. That money's going to the company, my company, and I'm not getting any value for it. So I'm coming down, I'm paying the full freight to the pharmacy. The pharmacy is keeping a piece of that because they're doing something with the transaction, right? But they're then paying the balance, basically buying the vial from the drug company. Sometimes it goes through a wholesaler, but they're paying list price basically to the drug company. The drug company is average wholesale cost. Drug company's taking that $300, right? And they're sending 225 of it or 200 and some plus to the left to that pharmacy benefit manager. So we see this green line coming across here to the PBM this guy is getting more than 2/3 of the transaction. In fact, in many cases, 75 to 80% of the transaction is going to this guy. How in the world is that possible? Welcome to America. We were all born here, but I'm welcoming you now. The PBM's job is to keep drug costs down. And they're doing that, it's just not for you. They're doing it for the plans. Their job is to create the formulary. Their job is to decide what drug, what insulin you get covered, what blood pressure medicine you get covered, what kidney, what heart disease medicine, whatever it might be. They decide what drugs are on that formulary. In the next slide, I will get into who they are, but the top 3 PBMs have 75 to 80% of the US market. 75 to 80% of the US. They have a lot of bargaining power. If you are trying to sell your product, you cannot give up 75% of the US market and expect to be successful. So the manufacturers are going to give them whatever heck they want. And you could say, how do you know that, George? I know that because of the slide that Jacob showed at the beginning with, look at the delta. They're giving them whatever they want because they can't afford to lose it. Now the Senate, United States Senate Finance Committee came out with a report on the price of insulin in January of 2021. It's 100 pages of wonderful reading if you want to get mad. And I urge you all to read it. The Grassley-Wyden. Thank you. I was close. Grassley-Wyden report. Really, really disturbing reading. They have a insulin manufacturer executive in an email saying, we are afraid to lower our prices because we will lose market share. That is in the report. And their behavior is proving that happening. So the pharmacy benefit manager, let's go back to the money, follow the money. He now has $200+ of the $300 you spent on that one vial. He's got $200. He's going to keep a piece of it because why wouldn't he? And then he's going to throw the balance up to the insurance company. Now, this is non-transparent. It is very difficult to know how much. Anecdotally, we think that the PBM's keeping 5 to 10 points. And 90 to 95% of the money of that rebate is going back to the health plan. So that, and in my case, an employer. So I'm a self-insured employer, it's coming to me. In Medicare, it's going to the federal government. So imagine that money is going to the federal government. That looks like a kickback.
Yeah.
Yeah, it kind of looks like a kickback. Yeah. When you have money that's going back up to the person buying, that's the kind of the definition of a kickback. It looks like a duck, it quacks like a duck, it's a duck. But the government in 2003 said that's not a duck. It's not a quick kickback, whack, whack, whack. It's legal. So that's how this started. Now the insurance plan is keeping this money, and they are saying, we're keeping the premiums down for everybody. Have your all premiums gone down? Anybody's gone down, raise your hand. How much it would, nobody, really, okay. But, okay, they didn't go up as much as they otherwise might have. Now we know that they wouldn't have gone up much at all, but you have the sick subsidizing the healthy, which is not how insurance is supposed to work. So we have a person with diabetes, a person with a chronic disease, because this is every drug out there. Our money is going to keep those that don't have pharmaceutical costs, we're keeping their prices down. That's not how it's supposed to be. I mean, the premise of insurance is the many help subsidize the cost of the unfortunate few. And that's not how drugs are working. So welcome to America. This is an absolute mess, but this is the marketplace that we live in. And the person driving this, and I wish this thing, that the PBM is driving this, and we're going to get into some of the other behaviors that they do. But let's talk about it's all in the corporate family. So how much the PBM kept versus the insurance company isn't really important because they now own each other. Over the past decade, really 5 to 7 years, they have gone on a buying spree and they've bought each other. So the left three, each of these columns, these are corporate families. OptumRx, CVS, Caremark, Express Scripts, that PBM line there, those three have 75 to 80% of the US market. Their parents, United Healthcare, Aetna, and Cigna, are the three of the biggest insurance companies doing health insurance. So they're now in bed with each other because so who keeps what doesn't matter. Oh, by the way, they also own the specialty pharmacies. They own the mail order pharmacy. So when you are told that you've got to go to and get your drugs through mail order, that's got nothing to do with the quality of the drug. It's got nothing to do with the cost, really. It's just that CVS and Optum and Express Scripts through their subsidiary make more money if the transaction goes through there. So that's what's driving that. And they also have provider services. It's all in one family. And the person they care least about is you, unfortunately. So that is an important thing to understand as the market has evolved, because it's all about the money.
So going back to our question about, are any of the players going to lower costs? And the answer is that it's going to take federal and state action to eliminate these rebates, or at least enact legislation that passes them through to the patients at the pharmacy counter. Now, in the meantime, manufacturers are releasing biosimilars, which, as we said, increases that market competition, helps drive at least that net price down. And those biosimilars are certainly at much more affordable rates, as well as improving assistance programs. Just last week, Sanofi announced, I believe, a $35 fee for a month's supply of insulin for those that are not insured at all. So,
And I'm pretty sure, not to sorry to interrupt, but I'm pretty sure the Sanofi, you don't have to prove insurance. You just sign up and for $35, they'll sell it to you. It may not work on Medicare, but my understanding is a pretty broad plan. Lilly has a similar one, $35 a month. You go to Lilly's website and you can get $35 insulin without a lot of questions, but it's not going through your insurance plan. So you're not going to get $35 worth of credit towards your deductible, but you're getting $35 insulin. So there is through Lilly, who makes Humalog, short-acting insulin, Sanofi making Lantus, the long-acting insulin. You can get all of your two insulin needs, if you will, your basics, covered for $70 a month by going through the manufacturing sites. So that's good. But you still got to go to the manufacturer. You got to log on. You got to get all that stuff. You should be you're fully insured, for crying out loud. You should be able to go and just get it. And we're not quite there yet. I'm sorry, Jacob.
No. And just to additionally highlight, we mentioned Sanofi and Eli Lilly, but it's true across all manufacturers that typically they all have assistance programs to help bring down that list price for the patient. And
go to the DLC, the diabetesleadership.org website. We've got a lot of materials on that as well.
So we look to Congress, and here's what Congress has put on the table so far, released in the 117th Congress. Last fall, there was lots of talks about the Build Back Better Act, which ironically had nothing to do with infrastructure at all, but included broad prescription drug pricing reforms and insulin-specific provisions. But however, as we all know now, that never really happened. Talks died in late December and have never really been brought back up based on the Senate makeup. Then we had the Affordable Insulin Now Act, which took most of those provisions from the Build Back Better Act, which was to eliminate deductibles for insulin and cap insulin copays at $35 per product per month for most people with diabetes insured. And now that was introduced in February of this year. It passed out of the House on April Fool's, ironically enough, by a tally of 232 to 193. And as might become the theme, the Senate has not moved on this legislation, despite them having their own version. But what the Senate has recently brought forward is the Insulin Act. And this was introduced by the two chairs of the Senate Diabetes Caucus, Jean Shaheen and Susan Collins, just last month. And so in addition to the provisions in the Affordable Insulin Now Act, which eliminates the deductibles and caps insulin copays, it adds a mechanism encouraging manufacturers to reduce their insulin list prices to 2021 net Medicare rates. And so that net, again, goes back to the rebate divide between list price and net price.
So that would be major if they would do, if we could get there. And Jake, what else is going in this thing?
So what does the Insulin Act have right? So the bill includes several positive steps that we've long advocated for in overhauling our nation's broken healthcare system. As I mentioned, it eliminates deductibles. So there's no longer a deductible period when it comes to when you have to pay for your insulin. You get immediately into that copay or co-insurance, depending on your plan, at $35 per product per month, or 25% of list price, whichever is lower. Because again, they're looking to try and bring down that list price so that people that are uninsured also can begin to better afford their insulin. And in addition to eliminating deductibles and capping copays, it bans health plan utilization management tools such as prior authorization or step therapy, or otherwise known as fail first policies, that require patients to jump through a lot of hoops just to get access to the insulin that their doctor prescribed for them. However, insurance plans often like to get in the way.
So step therapy isn't, for the record, getting 10,000 steps a day?
No, it is not.
Okay. I just make sure everybody understands that.
Yeah. But But to walk you through that just a little bit, at least, I'll just say step therapy is essentially where your doctor's prescribed you insulin A. However, your insurance plan thinks it's best that you try insulin B and C and maybe even insulin D before you actually get approval from the insurance plan to get to insulin A. So it'll require you to quite literally fail on however many insulins they might prefer over the one that suits you best.
And to use another example, anybody here on Ozempic, I know that we've got somebody on these, some of those drugs that are very expensive biologics, and you'll get told that you have to fail on something else first that's much cheaper. And so you basically go back to that generic, go have metformin first. And the story, I'm still blown away by that. But you have to fail on metformin before you can have Ozempic. What doctor is going to offer you Ozempic if you haven't already tried metformin? Seriously? Sorry, Jacob.
No, all good. And then one of the third things that comes with the Insulin Act is that it also blocks PBMs from negotiating rebates on covered insulins for which the manufacturer has reduced the list price.
So the good news is we have a bill that does something that we really need done, capping the cost of insulin at $35. I don't want anybody, in the room, whether in the front or the back or on the, watching online, to miss the importance of the fact that we have a live bill here. In advocacy, trying to get something passed, you can't get anything passed unless there's a bill dropped in the Senate, right? And when we say dropping a bill, it wasn't like I dropped my wallet and I got to go find it, although sometimes they seem like they're fleecing us. You have to have a bill for them to vote up or down. And so we're now at bat, if you're for a baseball analogy. We're swinging at the plate and people are throwing curveballs at us, but we have an active bill. So it's go time. All right, it's go time. We've got to get this thing through to the finish line. Yesterday, we were dealt a little bit of a blow. Do you want to talk a little about the reconciliation and how do you reconcile things?
Right, exactly. So as I mentioned previously, the Build Back Better Act, I'll just bring the slide back up. It included broad prescription drug pricing reform and insulin-specific provisions. And they were looking to pass this through a process called reconciliation, which would have only required the 50 Democrat senators to actually pass that into law. And so the Insulin Act is a more standard bill where it's going to require 60 votes to get past the filibuster and to actually get voted on. However, the Build Back Better Act, in some form or fashion, these prescription drug pricing reforms were brought back up just yesterday and were reintroduced to the Senate. And the unfortunate news is that they dropped all the insulin provisions. Now, why that is, I don't know. Perhaps they thought it might be more stomachable for some members of their own party as well as the opposing party, maybe trying to appease opposition. And the truth is we really don't know what's going to happen. Aides in the Senate are saying that the Insulin Act is what's going to help people with diabetes as opposed to this reconciliation package that is seemingly making its way through the Senate. But with behind the door conversations, it's really, truly hard to tell. But at the end of the day, the Insulin Act is the last word of this Congress on insulin provisions and capping copays for people with diabetes.
We have got to get this one through. If we don't get this one through, we're dead in the water. And again, having it not included in that reconciliation bill was a blow, because a 50 vote thing is a lot easier than a Senate, 60 votes out of the Senate. It's a heavy lift, especially during midterm elections, et cetera. Neither side wants to give the other side a win. So we've got some heavy lifting and some political gamesmanship to play with. They put on a strong face yesterday when it came out and the insulin stuff wasn't in there. Oh, we're gonna get the Insulin Act done, but they're gonna need our help to get that done, and they're gonna need some other help too to get that done. but we have a swing at the plate. One of the things that they're again that we have when you think about opposition to this, because some people say, why in the world wouldn't this just be a no-brainer? Whether you're Republican or you're Democrat, I mean, diabetes does not discriminate. We haven't really done the math on how many people would die, how many Republicans would have diabetes, and how many Democrats have diabetes, and how many independents would have diabetes. But I'm going to guess that the stats are going to draw just to like the general public based upon where you live, et cetera. So why would anybody be against it? And the issue that basically right now the Republicans have is they're looking at the $35 copay cap as a market price setting. They're against setting market price. They want to have free market flow. Our position is you're not setting market price. The market prices between the insulin manufacturer and the PBM and the insurance company just don't hurt the consumer. You're setting the consumer's price. And that's a different animal. But you know, that's when we go to lobby and we go to talk to members of Congress, that's one of the things that we've got to get across to them, because that's really what, in principle, what they're against, if you will. So now that are we suitably depressed or angry? Anybody ticked? Good. I hope you're ticked. So even if they pass this, which we all hope they do, medications will still be out of reach for some, okay? Because this doesn't help somebody who's not insured. You know, this is a copay cap for an insurance plan. And if you don't have insurance, this doesn't really help you. Now, if they lower the list based upon the 2021 net Medicare, it'll help them a little bit. But it's still going to be it's still going to be hard. So we still have work to do. Under a federal copay cap, it covers what you would think a Medicare, Medicaid, ERISA plans. A ERISA plan is a self-insured employer. So the plan at my company, we're covered under ERISA. Half the country is covered roughly under an employer-based plan. So that's you hear people talk about a ERISA plan. That's an employer-based health plan. And so that's about combined, that's about 85% of the country. That's a lot of people that would be covered. It's not everybody though. So you got 15% that would have to go to helped by the state. So everybody aware of state level, anybody have a state level copay cap on insulin that you're aware of in your states? Okay. Please come tomorrow morning and we're going to talk about state level caps and state legislation, and we will do the same thing. We will make you just as mad, but we will give you a little more hope because states actually move a little bit better than the federal government does at times. But the state level caps can only impact the state level plan. So that's state regulated plans, which basically anybody under the State Department of Insurance, the State Insurance Commissioner. So those are state plans, small groups, and sometimes the exchanges. So that's that. So until they pass it, what do we have to do? We got to look at biosimilars and generics, and those are the other tools that we have. But Jacob, what is a biosimilar?
It's a great question, George. So a biosimilar is a medication that is similar to another FDA-approved biologic medication, has no meaningful differences in terms of safety, potency, and purity. Now that term biologic, that's insulin. Insulin is a biologic drug. It's a medication that is made using living cells to produce complex proteins. Now, biosimilars are currently available to treat many serious illnesses, including diabetes. And then, as we mentioned earlier, insulin net prices continue to drop now that biosimilars are becoming much more available in the US. However, we'll touch on that a little bit more. And to really drive home the point, to compare it to your standard brand and generic, you've got a bicycle, and it's pretty easy to recreate a bicycle just in another form. And that's your basic prescription drugs, chemical, small molecules. However, when it comes to biologics like insulin, you've got genes and cells that you're trying to recreate and it's obviously very complex and hard to copy. And so instead of recreating the same exact engine, you're going to get a car that's going to drive you all the same as a regular biologic, but because it's a different cell, different tissue, it's going to look different, or it's going to, at the end of the day, be different than the exact biologic drug. So you've heard of brand and generics, but biologics have biosimilars. So that's all it is. So you've got a brand name drug and it's got a generic. Then you've got a biologic like insulin and it's got biosimilars.
So how many have a family recipe for that you've cherished? Grandma's apple pie, mom's lasagna, whatever it might be. I'm getting hungry just talking about it. And I see somebody in the back has that. So, you know, but you generations go down and you've lost the recipe, and in recreating it is very difficult. It's the same thing on the biologic. You've got to recreate that. It's never quite exact. It's never quite exact. Now, having said that, there is one biosimilar on the market today that is approved by the FDA as interchangeable. And I think the next slide takes me there, or maybe 2 slides later. It is, it's right here. Good. So these are the biosimilars that are out there. The main ones were Humalog, Novolog, Lantus. For years and years and years, those are the 3 that everybody understood. Those are the 3 that we're all taking from an insulin perspective: Novolog, Humalog, and Lantus. On Humalog, you've got 2 biosimilars. Admelog, which is made by Sanofi, and Insulin Lispro. Who makes Insulin Lispro? Eli Lilly. Who makes Humalog? Eli Lilly. Can anybody explain to me why in the world a manufacturer would make a generic biosimilar of their own drug? It sounds insane. I have been to their plant. It's going through the exact same process. It's the same plant. It's going into the same glass vial, and they're slapping another label on it, and they're making it a biosimilar. It's insane. Novo Nordisk, Novolog, Insulin Aspart is Novo Nordisk. Rely on Novolog. Oh, it's Novo Nordisk. There are 3 versions of Novolog out there, all by the same manufacturer. Why in the world would they do this? And the answer is they're getting the heck beat out of them because their list price is $300. Now you look at $275 and $289, and I paid $334 because the PBM actually jacks up things. So this is a suggested list, but they can't sell it. They cannot sell the branded version of their drug for less than they're selling it through the PBM contract. It's, they have a clause and they're not allowed to. They'd be in breach of contract. So the only thing they could do is create a biosimilar and put a new label on it and send it out to the market. They literally went through FDA approval to do this, which cost more than $5. Now, granted, it was a whole lot easier because it was the same thing, but they still had to go through all of that in order to come up with their own biosimilar of their own drug, so that they could offer it to us, the public, for a cheaper price. Again, it's still too expensive at $73 and $82. No argument there, but it's a whole lot better than 300 and some. Lantus has Basaglar, that's a Lilly product. Semglee is made by Viatris. Viatris is a new player in the insulin market as a biosimilar player. Semglee has been approved as interchangeable for Lantus by the FDA. It's the only one out there that has had that level of distinction. So it is, you could literally exchange that one for one. Most of the time, people are just, I'm taking 4 units for this, I'm going to take 4 units of that, and you don't think about it. But in Semglee, they've proven that you can do that. And in fact, in some states, the pharmacist can simply switch your prescription to Semglee without asking you or your doctor, because it's legal to do that. And many, that's a state by state thing. Many states, the pharmacist can't do that, but in some states they can, based upon how the FDA has approved it, which is fine. I think it's a good thing. I think it's a good thing that they went that far in the FDA approval process. It really should give all of us in the room, if you're given these, they've been approved. The the FDA has the most robust approval processes on the planet. We have the absolute gold standard. I spent 16 years in a business that did regulatory and compliance. And I know, and we did it internationally, and I know the FDA is the hardest one, the hardest threshold to meet. So if the FDA has approved it, it's pretty safe. Viatris, I digress. They came out with Semglee, and at the same time, they had to come out with a generic of their own, because they couldn't get the $99 version on anybody's formulary. The PBMs wouldn't pick it up. The PBMs wouldn't pick it up. So they had to come out with a $270 biosimilar, because no Express Scripts, CVS Caremark, Optum Rx wouldn't pick it up. So welcome to America. The lowest cost drug doesn't always win. Now, what you're about to see here is Medicare Part D data, because we have Medicare Part D data, it's public. But there's no reason to think that this isn't the same in a commercial plan. In fact, I pretty much assure you that it is. 2016 to 18, new generics launched at a savings of 30% on average, many times more. Only a quarter of them were covered in the first year. When a generic comes out at a lower price, you embrace that with open arms. Why wouldn't we all be, oh my, thank you, we've got a cheaper option for seniors, for senior citizens, for any of us. Only less than a third of it were covered at all in the first year. Less than half of generic products as we sit today are on generic tiers. So do we understand what a generic tier is? Because it's not just like I'm crying and the left eye and the right eye is the generic and the left eye is the real one. It's not that kind of tier. But when you're in a health plan, the tier of the copay is really what we're talking about. So the lowest cost tier is a generic. Then there's usually a preferred tier, which is usually a little bit more. And then there's the branded non-preferred, if they cover it at all. And then there's usually a fourth level would be the specialty drugs, where you might have a co-insurance where you're paying 20 or 30% of the cost of the drug itself versus $20, $35, $50, and your life savings. So the lowest cost, as a plan administrator of a self-insured health plan, I want my people to pick the lowest cost drug as long as it's going to work for them. So if I want them to be incented to take that lowest cost drug, but the PBM is putting less than half of it on the lowest cost tier because they don't want you to take it. They want you to take the drug that makes them the most money. Over the last decade, coverage on the generic tiers dropped from 93% to 43%. That's crazy. That's crazy. And oh, by the way, they're being sued. CVS Caremark is being sued for preventing access to generics to senior citizens. Who is suing them? Their own employee is a whistleblower who knows that this is what's going on, this practice is going on. So we're going to watch that lawsuit very carefully. This should boil our blood. What's going on with the PBM practices should boil our blood. So what's Congress doing?
Well, Congress has given another proposal in legislation, the Ensuring Access to Lower Cost Medicines for Seniors Act. And what it does is it requires that new generics and biosimilars be covered by Medicare upon launch, and that they be placed only on generic tiers with lower cost sharing and not the higher brand cost sharing tiers. And now it's important to note that although this bill specifically only addresses Medicare, a lot of commercial insurance plans often model themselves after Medicare's formularies. So as Medicare goes, often the commercial plans through ERISA will follow.
Yeah, and that's a really important point because most of us, this is children with diabetes. I don't know how many children are on Medicare at this point. Maybe our inner child, would take me there, but the commercial plans do the same thing. So one of the things that Diabetes Leadership Council does, we actually put on webinars to employers to educate them on plan design. And basically plan design mistakes they're making, they don't even know they're making, that are costing their employees and plan participants money. They're causing them to be non-adherent to their therapy, and they're raising the risk profile of one of the highest risk profile people on the plan. They'll give out apples in the lunchroom, they'll give out pedometers back to step therapy, but they'll charge $1,000 for insulin. What are you thinking? And they'll put the drug that they should be taking, they'll put it on the highest tier, and they're hurting themselves. And the one thing I didn't make this comment earlier when we were talking about the insurance premiums and all this money flowing through and keeping the sick subsidizing the healthy and really helping the healthy, because you feel good about helping the health. When I talk to employers, you're really not helping at all. The one thing you know about a person with diabetes in a health plan is they're going to meet their deductible 100% of the time. High deductible plan, PPO, we're going to meet our deductible 100% of the time. So if you make us pay $1,000 for insulin, congratulations, you're simply going to pay another claim prematurely, Mr. Employer. You're going to pay the next doctor visit because I'm now off a deductible. You're going to pay my next procedure. You're going to pay for the next round of insulin that you wouldn't otherwise had to pay yet because you overcharged me over here. But in the meantime, I rationed my insulin, and I'm far more likely to end up in the ER, which is where you're really going to spend a lot of money. So there's so many things that make no economic sense, but employers, insurance, they're just not using their brain. So is Congress our only hope? And the good news is, and I'll take the FTC because I love FTC. I used to think it was the folks that delivered flowers, but it's apparently that's FTD. But the Federal Trade Commission, everybody familiar with the Federal Trade Commission? Is that a group that as a health plan, people in diabetes, you think about the FTC very often? Yeah, not at all, right? These are the guys that typically tell you that there's a monopoly going on, and not monopoly money, but monopoly going on, and they got to break up Ma Bell and they've got to do other things. And they're looking at PBM practices. Finally. In February, the FTC was trying to decide if they should look into PBM practices. They had a kind of, they've been around a while. We've been complaining about PBMs for a while. And in February, they got together and said, should we look at this? Gee, I don't know. Should we look at this? And they decided no. They had 4 people in the room, and they couldn't decide amongst the 4 people, and they came up with a 2-2 split. And they decided, we're not going to look into it. And the world went ape over this. So the FTC then decided perhaps we should rethink that, and they added another person to the 5th person to the panel, if I'm not mistaken. So now you have a tiebreaker. So DPAC has responded to this. They asked for comment through April 25th. They then extended the comment period to May 25th. We give them all kinds of information on the business practices of PBMs. We've had other public comments. We then put a petition together, and DPAC advocates, and in full disclosure, we're going to ask you to become one if you aren't already, and I hope you are. Signed a petition. We had 590 people sign a petition to get the patient voice to the FTC. The FTC doesn't hear from patients, but they did through us, and they did through a number of chronic disease organizations, because this is not just a diabetes issue. And we're going to hear about that tomorrow if you come in for the state organizations. We got some exciting things that we're doing to try to move the needle at state level. They received over 24,000 public comments about how many people, and I don't think many of them were, how many think were favorable?
I'm going to guess max 1.
I think you're right, about 1. So the good news is they have issued a statement saying they're going to heighten enforcement of illegal bribes. and drug rebate deals that prevent patients from accessing lower cost drugs. Now, that's going to be interesting because they're now legal in the Medicare Modernization Act of 2003, but the FTC is going to look at it. This is beyond just rebates. What the PBM, rebates are just scratching the surface of the evil that is happening by these PBMs. Think of things like spread pricing. They'll buy a drug for one amount, they'll charge $30, I'm making this up, but this is the scenario. They'll charge $30 to a plan for a drug. So that means they're getting $30 from the health plan. They're going to pay the pharmacy $20 and they're going to keep $10. So the pharmacy only gets $20 to buy the drug from the manufacturer. Sometimes the drug costs the pharmacy $25, but the PBM is keeping that delta for themselves. They're not giving it to the employer, and they may be giving it to their parent because we know they all live together, but they probably not giving to the federal government. That's why the lawsuit exists, and they're certainly not passing it through to the patient or the senior citizen. That's just a tip of it. They also have practices that are putting community pharmacies out of business, I'm not here to help any particular industry, any particular line of business, but as a patient, we need to make sure we have pharmacists, especially if you live in a rural community that doesn't have a CVS or Walgreens on the corner. Those folks need to stay in business because if we all have food deserts, if we have pharmacy deserts too, it's not helpful. But the practices that are happening here are leading us toward pharmacy deserts in addition to food deserts that exist for other reasons that are not the PBM's responsibility. So just stay tuned to this. This is actually good news that they're looking at. And it's also an example of, in advocacy, it's not always Congress. It's not always the State House. Sometimes it's the FTC. Sometimes it's Medicare themselves. Sometimes it's the FDA. Sometimes it's the insurance company. We can advocate for anybody. What about other drugs, Jacob?
Well, we did say we'd talk about that. And so touch briefly on the Treat and Reduce Obesity Act, another bill in Congress. And so what this bill does is include Medicare Part D coverage of FDA-approved medications for chronic weight management, as well as expand the delivery of intensive behavioral therapy through other clinical and community specialists. That includes people like diabetes educators and honestly a lot of organizations that are represented here at this conference. Because as it currently stands, these IBT treatments are only accessible through the provider's office. They don't allow a lot of these people that are much more, well, I shouldn't say much more qualified, but differently qualified to help treat people with diabetes. And so why do we advocate for it? Well, obesity treatments can prevent or delay the onset of type 2 diabetes, as well as prevent or delay the complications of diabetes for those who already have type 2.
Yeah, or type 1. Forgive me, because people with type 1, because when I typed that, I actually should have clarified. I'm trying to lose weight, but there are many type 1s that have obesity as well. And we all know that having obesity leads to complications of diabetes. Diabetes and obesity kind of go hand in hand, specifically in type 2. But one of the things we know is if you have obesity and you have diabetes, however you got diabetes, you are more likely to have the complications. It's one of the other risk factors. We now have drugs to treat it. We now have drugs to treat it that didn't exist 5 years ago. So this is actually late-breaking news from the standpoint of, I think there's a drug, I'm not going to get the name of it out. I think it's a Lilly drug. Novo's got a drug. Several other folks have a drug. The Lilly drug have dropped people's body weight by 23% on the drug. And that's substantial. And the Novo one, I think, was 15% in that neighborhood. And a lot of people need this access. And I'm sorry I've interrupted, but.
No, but I mean, the last point is that this is the barrier to coverage that was built into Medicare Part D. Again, the reason why some of these medications weren't approved is that they were essentially the snake oil being sold to you at midnight on whatever TV channel you might have been looking at. But nowadays, we really need to update Medicare Part D coverage. And again, if you update Medicare, you can in turn hopefully guide the commercial insurance plans to hopefully adopt more of these chronic weight management.
Yeah. So a patient with type 1, we are all susceptible to getting obesity. Back in 2003, it was a very good thing to create a drug benefit through Medicare. It's a really good thing. The overall that law did a lot of good. On TV in midnight, you're selling fen. The drugs that they were weight loss drugs were killing people. They were it was making headlines. So they literally wrote into the bill that it can't be used for weight loss because the headlines were that buy the snake oil. So that's why. But now we actually have approved drugs that actually work, and our job as advocates is to get access to patients for the drugs they need, and we have a legitimate barrier to access that we need help on to get to knock down so patients can get it. So let's talk about what a patient. Oh no, let's talk about what Congress is doing.
So yeah, real quickly, as you look at this calendar, you can see from here on out, there's really only 2 windows left in which Congress could do something. 3, if you want to include a lame duck session after elections have happened. But needless to say, Congress is very much running out of time to take action on these issues. And so you've got the entire month of August. Now, they're not in DC, but where they are is back home in their districts. And so you can reach out to district offices and figure out, potentially schedule meetings with your senator representatives, or also look out for campaign events. Or I'm sure they're going to be in various parades and festivals campaigning for themselves. So just be sure to be on the lookout and make sure that diabetes isn't just a talking point for a lot of these politicians, but they're actually taking action to improve the lives of people with diabetes. So yeah, please definitely make note of the fact that the timeline is very short for this Congress for them to do anything before Election Day.
Yeah, we really think that the August 5th deadline there when the Senate goes out, that's going to be a key window. Whether anything happens in the September, October while they're running for election is anybody's guess. It'll be a miracle. If nothing happens, they may be a last-ditch effort at the lame duck session in December. But whatever happens in December will be because or now is because we're fighting for it right now. So don't have any compunction about what we do right now matters. So how do you become an advocate? Well, one, when you do it, tell your story. The DPAC, please sign up at DPAC, diabetespac.org. Register to be an advocate. We do not spam you. We don't sell your address. We are only going to let you know if there's something going on. And that could be at your state level, or it could be at the federal level. This talk's been at Congress, but we also do work at the state level. Please come back tomorrow morning and hear about that. When you do it, tell your story. Tell them why it cares. We're going to give you all the technical stuff about why they need to do what they do, but tell your story. I have a family member with type 1. I'm living with type 1. I've had this experience that's costing me whatever it is. Tell them your story. They want to hear it. It only takes seconds for you to type that. So please go ahead and do this. Please sign up. Also, for anybody who's questioning, I'm plugging DPAC. Please also do the same thing at JDRF. Please also do the same thing at the American Diabetes Association. Please also do the same thing at Beyond Type 1. Sign up on all of them. We sometimes follow different things. JDRF handles research quite well. You're not going to see DPAC lead on research. It's not that I'm not for research. Of course I am. I sign up through JDRF for that. We're not going to spend a lot of energy on that. We may link you to it, and we may follow it on social media, but sign up on all of them. Sign up on all of them. So you get 4 extra emails. It's worth it. And we have a consensus statement. We put 12 organizations, 12 national diabetes organizations got together in 2020 to talk about what do we need in health reform on behalf of people with diabetes. This is a really in-depth document that will similarly make you mad, but it'll tell you what we should be all fighting for, and everything we've talked about today is on this list. All right, thank you all so much. Appreciate you being here, and let's go make some change.